Good morning, and thank you for joining us for this edition of SBB University. I am your moderator and the publisher of Seniors Blue Book, Amanda Barton. Very delighted today to bring on a few of our very valued partners. We want to start with Daniel Smith, who's with Advocates in Aging. How are you this morning, Daniel?
I'm doing well. How are you, Amanda?
Very good. Thank you, sir. So tell us a little bit about yourself, how you got started in elder law, and we'll kind of bounce around to each of our panelists.
Sure, that sounds good. Well, I actually joined my father-in-law's elder law practice here in Sarasota about 4 years ago. We do Medicaid planning and application here, guardianship, general estate planning, special needs planning, probate and trust administration, and also do veterans benefits and appeals. So just really excited to be here and discuss Medicaid planning today.
Fantastic. All right, we're going to jump over to Marc Jacobs, who's with Earp Enterprises. How are you this morning?
I'm wonderful, Amanda. How are you?
Good, good. Now, you got a pretty cool background. Talk to me a little bit about, how you got started in the business and what you did in your past life.
Well, I've been a Florida resident since 2012. Before that, I was when I first moved down here, I was a limousine driver, believe it or not. I got used to talking to quite a few people, having one-on-one conversations in the car and whatnot, which I really enjoyed. I started getting into insurance about 3 years ago, which has over time has kind of led me up to be with Earp Enterprises. We do Medicare, supplementals, vision, dental, a little bit of life and all that. So been doing it about 3 years now.
Awesome. Thanks, Marc. Well, last but certainly not least, we have Elena Uttaro, who's joining us with Trilogy Home Health. How are you this morning?
I'm good. How are you? Thank you for having us.
Yes, ma'am. Wonderful. Well, we're really excited to have you as a partner. Thanks for coming on the partnership and joining us. So tell me a little bit about yourself. We want to get to know the lady behind the scenes, and then talk to me a little bit about what Trilogy offers.
Sure. So I've been in healthcare since 2010, have a full array of healthcare background from SNF to AL to now home health. I've been with Trilogy 4 years now, a great company. We offer Medicare Home Health with a lot of specialty services, respiratory, psych services, social worker, on top of your skilled nursing, physical therapy, and occupational therapy. And we partner a lot in communities with elder law attorneys and other resources that can help our patients out.
Now, that's fantastic. That the variety of different things that you've done in your past, I think, is what makes, it's such a great match for you, for sure. So today's topic, we're talking about Medicare and Medicaid. People are so confused about the differences between the two. I guess I never really realized how confused they are. So why don't we start with Daniel? Tell me, what is the difference between Medicare and Medicaid?
Sure. Yeah, I guess we'll start off with Medicare, because that's the most confusing thing about the program. Is a lot of people think it covers skilled nursing for an unlimited duration. Medicare is a federal program that's tied to Social Security. It's available to all U.S. citizens that are age 65 and up, and it covers individuals with certain disabilities. It's available regardless of your income. And when you think about Medicare, you think about the 4 parts, right? Part A is to cover hospitalization. Part B, your medical insurance. Part C is your privately purchased supplemental policy. And Part D covers drug coverage. Now, Medicaid is completely different. It's a joint federal and state program that helps low-income individuals and families pay for the costs associated with long-term custodial care, right? And so it was developed for low-income individuals. Certain states actually have Medicaid expansion. Florida is not one of those states.
Yeah, hey, Marc,
so there is long-term living or home care. It does cover some of that, but not fully cover. And I'll talk about the difference between Medicaid for assisted and home care versus Medicaid for skilled later. But that's kind of the key differences between the two programs.
Did the screen freeze for all of you or just for me?
Just for you.
Okay. Well, that's what's recording, and that totally stinks because about half of what you said was frozen.
I
And
can,
I don't-
You also froze once when you were talking earlier too.
Yeah, I don't know how to fix that. Shoot. I think I want to try it again, Daniel. I'm going to ask you the
Sure,
same
yeah.
question.
Yeah.
And Mark will elaborate obviously on what Medicare is, because that's his expertise. But I like the distinction that you're doing there.
Got
So
it.
let's try it one more time. I'm sorry, guys. I did shut down my other computer all the way, so I'm not sure what the problem is. Anyway.
Sure. The key difference between Medicare and Medicaid, first, let's talk about Medicare briefly. It's a federal program that is attached to Social Security. It's available to all U.S. citizens age 65 and up, and it covers certain individuals with certain disabilities. It's available regardless of your income. There are the 4 parts that I'm sure Mark will elaborate on, Part A, Part B, Part C, and Part D. But the important distinction is there is no income requirement for Medicare. Medicaid, however, is a joint federal and state program that helps low-income individuals and families pay for long-term custodial care, right? So this is important because there is strict eligibility requirements. There is an asset and income test. Medicaid for skilled nursing is fully funded, meaning if you qualify, you get the Medicaid benefits to cover the cost of custodial care in a nursing home. Obviously, there will be some patient responsibility, but that is huge because the biggest misconception is that Medicare covers your entire stay in a nursing home, and it does not. And also, there is Medicaid for assisted living and for home care available. Now, it's not fully funded. There is a wait list, and it's a stipend. It doesn't cover the full cost of care. But we'll talk about Medicaid more in full later. Thank you.
Yeah, definitely. There's such a misconception between the two. And I think it's incredibly sad when people walk into assisted living and they say, oh, I've got insurance. It's going to be fine. Oh, my Medicare will cover that. So Mark, we'll move over to you. The ABCs, I say, of Medicare of Medicare. It's such a confusing maze. For sure. So talk to me a little bit about, what Daniel was describing with the different types of plans, your ABC, D, E, F, G.
Wait until you get to the supplement part of it. There's even more letters than that. But yeah, Medicare does have 4 different parts to it. There's Part A, which doesn't cost you anything. There's no premium for it or anything, as long as you have 40 quarters or 10 years of working and paying your Medicare taxes. Part B is for doctors and for outpatient surgeries and things like that. That does have a premium base to it. On average, most people's going to pay currently for the year 2021, it's $148.50. If you make less than, as a single person, $88,000 or $175,000 as a couple. Part C is Medicare Advantage plans. Which most of them, there's different benefits and everything else that's added to them, but most of them are usually a 0 premium or very small premium plan. Part D is prescription drugs. That's where you get coverages for whatever prescriptions that you need. There's a lot of different, and there is an extra small premium on that also. So it all depends on what kind of fits into your budget as far as which one is the best option for you.
Yeah, and I think one of the first things I like to address is why is it so incredibly important to get a drug plan right away when you first sign up for Medicare? Even if you don't take medications.
Actually, when you first sign up for Medicare, it's important that you get your Part B in place along with Part D, because if you enroll late or don't enroll in time, there is penalties that come with it. For example, for Part B, if you have 90 days before your 65th birthday, the month of your 65th birthday, and 90 days after to enroll in it. If you don't make that time, or if you don't get enrolled in that time period, you can face a 10% penalty in your cost and the cost of the plan. A lot of people think that it is just for the initial enrollment, but it is not. It is for your lifetime. With Part D, it has the same sort of penalty, except it's 1% of the national average for a prescription drug plan. And again, that is calculated monthly, and that is not That is for the rest of your life, for as
Right.
long as you're on Medicare.
That's what I think people don't realize is that penalty will follow you for the rest of your life. And if you don't take any medications and you think you don't need it, but then, 12, 20 years later, you get a horrible diagnosis of cancer or something like that, and your medications on top of that penalty, it's just a lot to swallow.
It can
So
be,
it's
especially
important.
somebody that is lower income, because I mean, it might be anywhere from $30 to $50, but for a person that's on a fixed income, that can be quite a
Big
bit.
deal. Yeah. All right, Elena, come on to talk to us about the differences. So again, so many misconceptions. So we're breaking misconceptions, breaking the myths here. Talk to me about the differences between a Medicare certified home care company versus a home health care company versus a private duty or companion company.
Okay, so yeah, it's that is a little confusing. So Trilogy Home Health falls under your Medicare. So your Medicare Home Health is 100% covered. It's the skilled part. So for instance, you fall, you go to the hospital, you are a little weak after your hospital stay, you have a hip replacement, you need home health. Those services, skilled nursing, physical therapy, the medical part is covered under your Medicare Part A.
Right.
So you won't have any out-of-pocket costs for our services. So all of our services, we do what you call a 60-day certification process. So we would enroll you for, let's say we would start you and it would go for 60 days. However, that doesn't mean that you'll be with us 60 days. Medicare will cover as long as medically necessary. So let's say a patient is with us 2 weeks and then they're good and ready to go. Then we would just discontinue the home health. Let's say they go longer than 60 days. Let's say 60 days comes and they are still showing that they need home health. We can recertify them. They don't have to do anything. We do all the back end work with your doctor and get all the orders that we need from your doctor. And then we just keep going. So Medicare will cover as long as medically necessary at no cost to the patient.
Right. And you do actually have to be homebound, and you do actually have to have a doctor's note, which I think is incredibly important for people to know that they can't just necessarily call you up.
So yeah, they can, but then there'll be some homework that we have to do on our end to make sure that we have everything covered from the doctor's standpoint, making sure that they are homebound. I don't really like to say, homebound could be, technically it just means that they're not 100%. So as long as they're not, driving to the mall every day and getting their hair done every day,
Go
or go golfing, they can't say, oh, I have a 6 a.m. tea time, sorry. Then that would be an issue. So what I like to do is just let the doctor and our clinicians determine then at that point when they see the patient, is this patient homebound? Can we provide services under the Medicare guidelines to service this patient?
Right.
But yes, technically, yes, you need to be homebound and we do need a doctor's note.
And you guys, Medicare is not going to pay for somebody to walk your dog, for example. So that's where you really marry up with private duty.
So that's when we would refer out. We would refer out, if let's say they have a hip replacement and they can't get up to go walk their dog, then we would call in what we call private duty, a companion to come in. And then that is home health, but it's more of a private duty situation. And there's many different agencies you can use, but those agencies would come out. We can make the referral to them, with the ones we work with. And then at that point they can come out and then they can go walk the dog and they have their hourly fee.
Or you can check your local seniors blue book for a list of
that is correct.
Private duty home companies. Right, Daniel? All right, moving on along down to Daniel. Now, you touched on this. There are some stringent guidelines when it comes to qualifying for Medicaid. So let's say somebody's trying to pre-plan and they're on the brink of being able to qualify, but they're not quite eligible financially. First of all, talk to me about the qualifications of what you would need to be, your income needs to be, and then what are some of the tricks of the trade to help those folks that are, in that limbo stage?
Sure. First, I take a step back and I meet with the families and say, first, do you have advanced directives? What are those advanced directives? What do I mean by that? is there a designation of healthcare surrogate? And probably more importantly, is there an agent under durable power of attorney? Because who is going to be signing the application documents and any of the planning documents that we may need on behalf of the nursing home recipient? Because if there isn't one, then we really need to think about drafting new ones, updated ones, and we may have to schedule that signing in the facility if the individual is already placed. Because, and for instance, if there's an older durable power of attorney, there may not be authority on there to be able to create a trust. And if we can't create a trust and the income is above the cap, then we're out of luck. We may have to file a guardianship to get that authority. So going back to the exact requirements. So currently the income limit for an individual in Florida is $2,382 a month. If the income exceeds that amount, we can create what's called a qualified income trust and pass the income through that and then pay the facility. So that we can, as long as the proper planning's in place, get around. The asset limit is probably the trickier one because it's only $2,000 in countable assets. Now, first we say, is the nursing home recipient married? Because then we can look at the community spouse resource allowance, meaning there's a certain amount of funds, currently around $130,000 in countable assets that we can set aside to protect that spouse that's living in the community, right? Whether it be in the home, just not in the nursing home. But we need to look at the type of asset, right? Because it's only $2,000 in countable assets. Then one of the biggest misconceptions is Medicaid going to take my house? Right. The answer is no, right? The homestead is exempt and protected under Florida constitutional law. And there is an equity limit up to $603,000, right? For that primary residence that's going to be exempt. So that's probably the biggest fear that is alleviated, is that no, Medicaid is not going to take the home and it's protected. Now, if you have $1 million homestead, right? There's the huge mansion out on Longboat Key, then there's some different planning that's going to be involved at that. But at that point, you say, well, why are you applying for Medicaid, right? Can't you private pay this? So that's a whole different conversation. But another big one is retirement accounts. Florida is one of the states that exempts retirement accounts as long as the individual is taking the required minimum distributions. So that could be a fairly large asset as well. Now, the distributions are going to count as income, but that's, again, we can handle that with the qualified income trust. So the first part before we think about any spend down is let's look at each asset and see if it's even countable. And then we can talk about any type of spend down strategies.
Yeah, it's a lot to absorb and a lot to take in, that's for sure. And I think one of the big things to talk about when we talk about spending down, we're not talking about giving, $100 grand to your kids. We're talking about legitimately speaking with a professional to make sure that gifting isn't done incorrectly, so it comes back to bite you, right?
Right. Yeah, and I'll just add to that Medicaid has a 5-year look back, meaning you can't just gift away all of your assets to get under the limit, right? Without Medicaid knowing. Now, most people don't plan this far in advance, and usually the nursing home stay kind of sneaks up on you. But obviously there's ways to protect the assets if you're not going to be needing skilled nursing 5 years down the road. But you almost have to have a crystal ball at that point, and a lot of people don't like to give away control of their assets. So that makes planning kind of tricky when you talk about transferring assets to an irrevocable trust and the limitations on that. But there are strategies that you can do in kind of crisis Medicaid planning where the individual's in a facility and we need a Medicaid pending this month, right? Yes. And one of those, purchasing rental property is a good one because rental property is exempt as long as it's fair market value and you're getting rent, fair market value rent. Another one you hear about with Medicaid planning is personal services contracts, where there's actually a care provider providing the care that Medicaid doesn't want to pay for. And it could be, a family member or somebody close to the family who can provide those services under a contract. And Medicaid will allow that as long as it's based on the life expectancy of the nursing home recipient. So that's another strategy that we look at to see who's, in the area and can provide those services.
Yeah, and it's really, really important to talk to a professional. You know, don't make the mistake of doing it on your own. All right, Mark, I'm going to jump back over to you. Now, it's so confusing what's the difference between your supplements versus what are some of the different choices that you can make out there when you're in open enrollment period? And when would there be a special election where somebody might not have to do this during open enrollment?
Okay. Well, the different options that you have after you get original Medicare, which is Part A and Part B. The one thing a lot of people don't know is that original Medicare only covers up to 80% of your hospital expenses, and it's not capped, it's unlimited for as long as it goes. So to help cover that other 20%, you have two other options. One is a Medicare Supplement. It's also called Medigap. That is an extra premium that you pay on top of your Part B premium. And like we talked about, when you made the comment earlier, there's tons of different plans, and right now the current letter system is formed now. They run anywhere from Plan A all the way to Plan N. There's different options that covers different things, have different deductibles. With a supplement, that's when you also have to get a standalone Part D plan, prescription drug plan. Again, that has a separate premium, and that is usually based on what is the best option for you. Depends on the medications you're on, depending on what the formulary is on the plan. Your other option, Advantage plans, do come with prescription drug service. The best way I can explain it, it's like the difference between Medicare Supplement and Medicare Advantage is with Medicare Advantage, you kind of you rent the car, or it's like buying a car. Okay, you're going to have different little add-ons and everything else that when you're buying the car straight out, you're paying for the price of the car up front. So if you're somebody that wants to go into a doctor's office and not have to worry about any sort of bills or anything else, and depending on what your income level is and you can afford them, a Medicare Supplement plan might be a little bit better for you. But a Medicare Advantages is like leasing the car. That you only want to pay for it as you go, as far as the maintenance and everything else goes with it. So on a Medicare Advantage plan, it's for people that want to pay as they go, because there's going to be copays and small deductibles inside of it. But it does have, just like insurance on the under 65 market, it's going to have what's called a MOOP, which is a maximum out of pocket. So you'll know exactly from year to year that how much it's going to cost you for your Medicare coverage in case something serious happens. There's a few other differences, but to me, that's the basic gist of the difference between the two of them.
Yeah, I love hearing the different ways that brokers describe it. Some of it say like, oh, it's an all-you-can-eat buffet, or, you know, do you want to go into a restaurant and buy a fancy steak? And then you've got the car reference. So I love that. That's great. Now, the secondary question that I had for you, when would there be a special election period? Because there are some special circumstances.
Well, there's usually two open enrollment periods during the year. The first one is what's called the open enrollment period. It runs from October 15th through December 7th. And that's every year. And that's for anybody that's on any sort of, whether it's Medicare Supplement, prescription drug plan, or a Medicare Advantage plan. There is also a second one that happens every year, and it runs from January 1st through March 31st. Those are for people that are exclusively on Medicare Advantage plans. It gives them the opportunity, if they want to leave that Medicare Advantage plan and go back to original Medicare and pick up a prescription drug plan, you can do that at that time. There is several different options that open up during the year that's called special election periods. Usually it has to do something, there's a special election that you can get if you have a change of address. There's also another one that happens that can come up that's through FEMA. We've had two of them here this year, and it's usually due to a weather issue or things of that nature. There was a special enrollment period that's currently in effect now, as a matter of fact, for the hurricanes we went through here a couple of months ago down in Florida. And they vary from state to state and everything else.
Yeah, perfect. Thank you. All right, Elena, back to you. Now, I think it's incredibly important to talk about patient choice, because you do need that doctor's note when you're getting home health. But really people need to educate themselves because it is still your choice, and your doctor may recommend a company or not even recommend a company and just write you a script. So talk to me about how that works and how to have that conversation with your doctor.
So I'll just use myself as an example, or I'll use myself. So I go to my doctor's office and I say, hey, I have a relationship with Trilogy Home Health. I've had them before in the past. I'd like to use them. 99% of the time, the doctor's going to say, okay, if that's what you want to do. The only time a doctor will sometimes say, no, I really would like you to use this agency is if he has a special clinician that he likes to use for a specific protocol. But again, the doctor's going to go with whatever the patient wants because it is patient choice. And because there's so many home healths out there, it is important for that patient to have that patient choice. So they just need to just tell their doctor, hey, I'd like to use Trilogy Home Health, and they would write the order.
Now, and talk to me about the how Medicare pays for it, when you may start over, a reoccurring episode, things of that nature.
So, like I said previously, it's a 60-day certification period. So we certify a patient for 60 days. Whether or not they use that full 60 days, they don't have to do anything. We do everything on our back end. So what we'll do is we'll bill Medicare for however many visits that we're seeing the patient. If it goes over the 60-day mark and they need more help, then we'll resubmit for recertification. We'll let the patient know, hey, we're going to keep going with your home health. They don't have to do anything. We get everything on our back end from the doctor, and we communicate everything with the doctor. Let's say they discharge from us. A week later, they call us back and they say, you know what, we thought we were good, but you know what, I think I need more help.
Yeah.
Then at that point, there is no waiting period. They can immediately start again. We would still need a new doctor's order. We would still need, it would be like a new start, but there is no gap. Like the other services that Medicare offers, sometimes there's a gap period. There's no gap for us. We can start right away again.
Yeah.
We can go in as long as we need to.
Yeah. Yeah. And is there an opportunity where you can do inpatient and outpatient therapy if you're released, or do you kind of have to choose between one or the other?
So you would need to choose between one or the other. A lot of times we hop back and forth. So because outpatient is covered under their Part B, Medicare Part B, and we're Part A, you can't use the same at the same time. So what we do is then we can piggyback off and forth. So if they're doing an outpatient treatment, we can say, okay, we'll put you on hold until you're ready to come back. And then once you're off that outpatient therapy or whatever it is that you're doing, then we can then come back to us. And then again, we'll need a doctor's order, but we can work on that. That's nothing the patient has to worry about.
You guys usually do all that behind the scenes and they don't even realize it's happening. So sure. I know that we talked about coming out of surgery or rehab or the hospital. What are some of the other most common things that people would need your services for?
So besides the obvious, a lot of times we'll get a patient that maybe has a new medication or maybe they have a new diagnosis. We are fortunate enough to have a certified dementia practitioner who can also help us with a new onset of a new diagnosis. So let's say they have a new dementia diagnosis. We can have our Pam Pulowski, who works with us, can go out and do a full assessment and then really determine, here, what are the next steps? Who needs to be involved in that care? So we can kind of help them with that. The other thing is Psych Services. So maybe, in this day and age and time, we're in a weird time right now. Maybe they've been put on new medications. We can go out there and monitor the adjustment for the medication.
Yeah.
We can help them set up we give them a nice little pill box. We can put all their medications in there. Or maybe they just need a social worker. Maybe they just need someone to come out and talk to them and get them all set. And we can, help them with resources and kind of help them through their situation.
No, that's perfect. One more quick round of questions. Daniel, a lot of people have the misconception that skilled nursing and assisted living, when they're looking to qualify for Medicaid, are the same coverage. I mean, I've even seen it where families have called and said that, oh, I thought this was going to be covered 100%. So talk to me about, there's two different programs. You've got your diversion program, your long-term care. So can you kind of go into the differences between the two?
Sure, I'll talk about first Medicaid ICP. That's the Medicaid for skilled nursing, because that's the one most people think about, because that's fully funded. If you're eligible, right, asset and income wise, Medicaid will cover the full cost of care, right, in the skilled nursing facility, minus your patient responsibility. So what is that? Essentially, it's just the nursing home resident's income minus $130 each month that they're allowed to keep as part of their allowance, right?
Mhm.
So, but they cover, you know, skilled nursing, $9,500 and up a month. So that's a huge benefit if you can get qualified for Medicaid to not have to pay that each month. Now, the trickier question is for Medicaid waiver, right? Medicaid for health and community-based services. Under that program, that one is not fully funded. There's a wait list, and you actually contact the Area Agency on Aging to get on the wait list.
Yeah.
And they actually have a form, and they will give you a score, a ranking, based on, you know, the care that's needed, and you can kind of continue to contact them as the help progresses to try to see if you can get bumped up on that wait list. But you know, sometimes that can traditionally up to 1.5 years on that wait list. But again, you can get bumped up. And it's not for the full cost of care. It is a stipend. So you're not looking at, like, if you're in an assisted living and you may need memory care, you know, that can be $6,000-7,000 a month. And unfortunately, even with the Medicaid waiver benefit, the income might not be enough to satisfy that. That's why it's important to look at the individual's income and any other benefits, right? Veterans benefits too. A lot of times families don't think about, including for surviving spouses. So you need to look at the whole picture first and see what's going to be obtainable in paying for care.
And that's why it's so important to pre-plan, because really Medicaid is only going to cover your care. It doesn't cover your room and board, and care, the room and board is going to be $3,500 to $6,000. And that's, again, you know, there's this loophole of people, the donut hole of people, and Mark, you're used to that word, talk about it. But there's that group of people that definitely can't afford that, but yet they don't qualify for Medicaid. So it's important that you pre-plan and really take all that into consideration and meet with someone like Daniel ahead of time. All right, Mark, do you want to talk a little bit about the donut hole? I wanted to ask you that, and I also wanted to make sure to ask you about the differences between Plan F and Plan G, because I know, you know, Plan F is no longer available or for people that are just coming into it.
Yeah, well, Plan F is still available. It just, if you turn 65 after September 1st of 2020, then it's no longer available. But if you turn 65 before then, you can still get on a Plan F. The main differences between a Plan F and a Plan G is you have a Part B deductible that is currently $203. That the Plan F covers, the Plan G does. On a Plan F, everything else on the G is covered just like it is on an F. But the difference is that you're paying anywhere, but depending on the provider, you're paying anywhere from $30 to $50 more a month for that Plan F than what you would for Plan G. So if you do the math, even on the low side of $30, you're paying $360 a year extra to cover $203. It doesn't make sense. One thing that I like to talk about as far as when it comes to Medicaid is that it also changed. There's also a lot of different options that when it comes to Medicare that also helps you when you qualify for Medicaid. There's programs out there that is called, one is the LIS, which is the limited income subsidy. That can help you get not only pay for your Part B deductible or your Part B premium, but it can also help you pay for prescription drugs, which would keep you out of be very important to people to keep them out of the donut hole. They wouldn't have to worry about that. And it also helps qualify them for some Medicare Advantage plan. Stands for dual special needs plan. You need to be Medicaid eligible or qualify for Medicaid and Medicare both. That's where you see Joe Namath and Jimmy Walker on TV talking about free rides to the doctor. It helps coordinate the two plans together. Okay, so that's one thing that's real important. Now, when you're talking about the donut hole on a prescription drug plan, there's 4 different stages. One is the deductible stage, is the first stage, and usually most plans, most standalone plans have a $435 currently deductible that you pay up front. Then you go into the initial coverage stage. And currently it's $4,130 if memory serves. that you stay in that stage, which you pay a set copay or a deductible for the medications you're at. Once you come out of that stage, then you go into what's called the donut hole. Donut hole, after you get 4,130, you're in the donut hole up until you have $6,350, memory serves, that you're 100% responsible for, or not 100%. I'm sorry, I said that wrong. Up until last year, you were responsible for your drug costs in that stage. Effective in 2020, they changed that, where instead of having the set copay, now it is 25% of whatever your drug cost is. After you come out of the donut hole, which is, again, it's 6,350, then you pay, it's a small fee for like $3.70 for any sort of generic drug, or for a specialty drug, it's $7.95, or 5%, whatever is the lower amount, whatever is the lower amount, and that will continue until the end of the year. Every year on January 1st is when all prescription drugs plans reset, and you kind of start over and go through the same system again.
Perfect. All right. Thank you, Marc. Elena, I'm going to jump over to you. So just to kind of wrap things up, you have so much experience in so many different areas. What would you say? And usually my Medicare home health people are very passionate about like talking about the differences between like a traditional plan when it comes to skilled nursing and keeping your supplemental. Kind of just wrap things up for us and tell us what your thoughts are on that, and when it, especially when it comes to having patient choice.
So I always say, let's do what's best for the patient. So, I think you have to do what's best for the patient, what needs they have. We take traditional Medicare, so we don't necessarily use their supplement. If they have a high need and they have something, that I always try to stay out of that part of it, and make sure that they do what's best for them. They talk to their doctor, they make sure that they have their choices laid out. And, Marc did a really nice job explaining, the different angles that you can take, because there's a million different angles that you can take with that. So you do what's.
Is she frozen or are all of we?
Not frozen.
Nobody's frozen on my end.
No, I heard Elena fine here.
Yeah, I didn't hear you wrap it up, man.
So no, I just basically said, it's patient choice. Marc did a nice job laying out kind of the different choices that you have, but it's always best. Everybody's clinical situation is very different. We take traditional Medicare. We don't. Any Medicare home health agency, we do not use a supplement. It is just a straightforward Medicare supplement. But I do, I'm a big patient advocate and doing what's best for the patient. So looking at the big clinical picture for the patient, getting with your doctor and finding out, is a replacement plan better for you, or is it a traditional Medicare, and just really kind of ironing out what you need and what fits best for you.
Perfect. Well, thank you all so much for spending some time with me this morning. This is it's a topic we could probably talk about for hours. If you have any questions, please check the chat above for the contact information of all of our panelists today. And until next time, I appreciate your time and your partnership with Seniors Blue Book.